This video is for educational purposes only and is not intended as medical advice. Please consult a qualified healthcare professional before making any health-related decision.
Most people expect heart problems to announce themselves with pain, urgency, and alarm. But what if the very first signal is simply feeling tired in a way that doesn't make sense? Unexplained persistent fatigue is often one of the earliest and most overlooked signs of heart dysfunction in seniors. It does not arrive as dramatic exhaustion after heavy labor. It appears quietly. A person who once moved comfortably through daily routines begins to feel drained by ordinary tasks. Folding laundry feels heavier. A short walk requires more pauses. Conversations seem to demand more effort. It is subtle enough to dismiss, yet consistent enough to change behavior. To understand why this happens, we must look at the fundamental role of the heart. The heart is not merely beating. It is maintaining pressure gradients that allow oxygen and nutrients to reach trillions of cells. Every movement, every thought, every repair process inside the body depends on a continuous supply of oxygen-rich blood. When cardiac output, the volume of blood pumped per minute, declines even slightly, the effect is systemic. Muscles receive less oxygen. The brain senses lower perfusion. The kidneys adjust fluid balance. Energy production inside cells becomes less efficient. In seniors, structural changes gradually influence this efficiency. The heart muscle may thicken in response to years of pumping against stiffened arteries. The chambers may not relax as easily during filling. This condition, sometimes described clinically as diastolic dysfunction, reduces how much blood the heart can accept and then eject with each beat. Even if the heart rate appears normal, the total delivery of oxygen may be subtly compromised. Cells generate energy primarily through aerobic metabolism inside mitochondria. Oxygen is the final electron acceptor in this process, enabling efficient production of ATP, the molecule that powers muscular contraction and neural activity. When oxygen delivery falls, even modestly, the body compensates by increasing heart rate or extracting more oxygen from circulating blood. But compensation has limits. Over time, tissues begin operating closer to their threshold. The result is a pervasive sense of low energy that rest does not fully restore. What makes this fatigue distinct is its disproportionate nature. It does not correlate with exertion. A senior may wake up already feeling tired despite adequate sleep. The fatigue may persist throughout the day, creating a heaviness that feels internal rather than muscular. It is not the soreness of overuse, it is the depletion of insufficient supply. There is also a neurological dimension. The brain is exquisitely sensitive to changes in blood flow. Even small reductions in cerebral perfusion can influence concentration, mood, and alertness. Seniors experiencing early cardiac decline may describe brain fog or difficulty focusing. They may attribute it to aging alone, yet the underlying mechanism may involve subtle circulatory compromise. The body attempts to adapt intelligently. When cardiac output decreases, the sympathetic nervous system activates, heart rate increases. Blood vessels constrict to maintain blood pressure. Hormonal pathways such as the renin-angiotensin or aldosterone system stimulate fluid retention to increase circulating volume. Initially, these responses stabilize circulation. However, they also increase workload on the heart. What began as compensation can become strain. Persistent fatigue, therefore, is not weakness. It is a physiological message. It reflects the mismatch between metabolic demand and circulatory delivery. In seniors, this mismatch may develop gradually over months or years. Because the progression is slow, the individual adjusts behavior unconsciously, reducing activity, sitting more often, declining invitations, shortening walks. These adaptations can mask the symptoms' seriousness. Another critical factor is skeletal muscle conditioning. Reduced cardiac efficiency often leads to decreased activity levels. Muscles then decondition, losing strength and mitochondrial density. This creates a feedback loop. Weaker muscles require more effort for the same task, increasing perceived fatigue, which further reduces activity. What appears to be simple aging may actually be the interplay between cardiovascular limitation and muscular adaptation. Clinically, unexplained fatigue may precede more recognizable signs such as chest discomfort or swelling. It can be present in conditions ranging from early coronary artery disease to evolving heart failure. In coronary artery disease, partial blockages limit blood flow during exertion, reducing oxygen delivery not only to the heart muscle but to the entire system. In early heart failure, the pumping capacity declines enough to impair systemic perfusion before fluid accumulation becomes obvious. It is essential to differentiate this fatigue from normal age-related slowing. Aging alone does not create persistent, unexplained exhaustion. Healthy older adults can remain energetic and active when circulation is intact. The key distinction lies in change, a noticeable reduction in stamina compared to one's own baseline. Medicine is less about comparing individuals to others and more about comparing them to themselves over time. There is also an emotional dimension worth acknowledging. Fatigue can influence identity. Seniors who once prided themselves on independence may feel frustrated or embarrassed by their reduced energy. They may conceal symptoms to avoid appearing vulnerable. This silence delays evaluation and intervention. From a scientific standpoint, early recognition of unexplained fatigue provides an opportunity. Diagnostic tools such as echocardiography can assess ventricular function. Blood tests can measure biomarkers that reflect cardiac strain. Stress testing can evaluate coronary circulation. When identified early, many cardiac conditions are manageable with medication, lifestyle adjustments, and structured exercise programs that improve efficiency without overburdening the heart. Perhaps the most profound insight is that fatigue is not the enemy, it is information. It signals that the equilibrium between supply and demand is shifting. The heart is working, adapting, compensating, but perhaps not as effectively as before. When we respond with curiosity rather than dismissal, we transform a vague symptom into a doorway for prevention. In seniors, listening carefully to unexplained persistent fatigue can preserve strength, mobility, and independence. It allows intervention before crisis, before hospitalization, before irreversible damage. It is the earliest whisper in a language the body has always spoken, asking not for fear, but for attention. There is a particular kind of breathlessness that does not arrive with panic, but with puzzlement, a quiet awareness that something once effortless now requires intention. Shortness of breath during mild activity, or while lying flat, is one of the most clinically meaningful early indicators of heart dysfunction in seniors. It often begins so gradually that it blends into daily life. A person who once walked comfortably through the market now pauses to catch their breath. Climbing a few steps requires a slower pace. Even speaking for extended periods can create the need for a deeper inhale. These are not dramatic collapses of capacity. They are subtle shifts in physiological reserve. The heart and lungs function as an integrated system. The lungs oxygenate blood, the heart distributes it. When this coordination is precise, oxygen delivery meets metabolic demand seamlessly. But when the left ventricle, the chamber responsible for pumping oxygenated blood to the body, begins to lose efficiency, the consequences ripple backward into the pulmonary circulation. If the left ventricle cannot eject blood effectively, pressure increases within it during filling. This elevated pressure transmits to the left atrium and then into the pulmonary veins. The lungs, which are structured for gas exchange rather than fluid storage, respond poorly to sustained pressure elevation. Even a modest rise in pulmonary venous pressure can push fluid from capillaries into the interstitial tissue surrounding the alveoli. The alveoli are microscopic air sacs with walls so thin that oxygen can diffuse rapidly into the bloodstream. This diffusion depends on a delicate membrane and minimal distance between air and blood. When fluid accumulates in the surrounding interstitial space, the diffusion barrier thickens. Oxygen transfer becomes less efficient. The body senses this inefficiency quickly. Specialized receptors in the carotid arteries and brainstem monitor oxygen and carbon dioxide levels continuously. When oxygen delivery drops or carbon dioxide rises, respiratory drive increases. The individual begins to breathe faster or more deeply. This physiological adjustment is protective, yet subjectively, it feels like breathlessness, an uncomfortable awareness of breathing that was once automatic. What distinguishes cardiac-related shortness of breath from normal exertion is its disproportionate nature. The level of activity required to provoke it is modest. A senior may feel winded while dressing, bathing, or walking across a room. Rest often relieves the sensation, but over time, the threshold for symptoms lowers. The body's reserve capacity is shrinking. Another important manifestation is difficulty breathing when lying flat, known clinically as orthopnea. When a person reclines, gravity no longer pulls blood toward the lower extremities. Venous return to the heart increases. In a healthy cardiovascular system, this additional volume is accommodated without difficulty. In a heart with impaired relaxation or reduced pumping strength, the increased preload raises left-sided pressures further. Pulmonary congestion worsens. The individual may instinctively use extra pillows or prefer sleeping upright. This adjustment may seem minor, but it reflects measurable changes in cardiac mechanics. There are also episodes where a person awakens suddenly at night feeling breathless. During sleep, fluid that accumulated in the legs during the day redistributes into the central circulation. Combined with reduced sympathetic tone, which normally supports cardiac performance, this shift can temporarily overwhelm a weakened left ventricle. Sitting upright allows gravity to reduce venous return and relieves pulmonary pressure. The improvement feels immediate, but the underlying issue remains. From a physiological perspective, breathlessness is not solely about the lungs. It is about oxygen delivery relative to demand. When cardiac output declines, skeletal muscles performing even mild activity receive less oxygenated blood. They transition earlier to anaerobic metabolism, producing metabolites that stimulate ventilation. The sensation of needing more air is both a pulmonary response to congestion and a metabolic response to inadequate perfusion. Aging does bring gradual changes in cardiovascular compliance and maximal aerobic capacity. However, healthy seniors typically adapt without pronounced dyspnea during routine tasks. The critical factor is change from baseline. When daily activities that were once manageable now provoke breathlessness, the body is signaling altered hemodynamics. The heart often attempts compensation. Sympathetic activation increases heart rate and contractility. Hormonal systems retain fluid to preserve blood pressure. Blood vessels constrict to maintain perfusion to vital organs. These mechanisms are adaptive in the short term, but they increase cardiac workload. Over time, they can exacerbate congestion and further reduce efficiency. It is also important to recognize that breathlessness can lead to behavioral adaptation. Seniors may reduce activity levels to avoid discomfort. This decreased activity leads to deconditioning of skeletal muscles, reducing mitochondrial density and endurance. As muscles weaken, even less exertion is required to provoke dyspnea. A cycle forms. Cardiac limitation leads to inactivity, which amplifies perceived breathlessness. Clinically, early shortness of breath may be associated with conditions such as coronary artery disease, hypertensive heart disease, or evolving heart failure with preserved or reduced ejection fraction. In some cases, heart rhythm disturbances impair coordinated contraction, reducing effective stroke volume. The unifying principle remains the same: inadequate forward flow and elevated backward pressure. There is also a psychological dimension. Breathlessness generates anxiety because breathing is fundamental to survival. Even mild dyspnea can create apprehension, which in turn increases respiratory rate and heart rate, intensifying the sensation. Distinguishing between primary anxiety and physiologically driven breathlessness requires careful attention to context, triggers, and progression. From a diagnostic standpoint, evaluation may include imaging to assess ventricular function, measurement of natriuretic peptides that reflect cardiac wall stress, and functional testing to evaluate exercise tolerance. Early identification allows intervention through medication, dietary sodium regulation, fluid management, and structured physical conditioning designed to improve efficiency without overburdening the heart. Perhaps the most meaningful insight is that shortness of breath is rarely random. It is a mechanical consequence of pressure, flow, and diffusion. When these variables shift, sensation follows. In seniors, the onset may be gradual, almost polite in its presentation, but it represents a significant physiological message. To listen carefully to early breathlessness is to respect the interconnected design of the cardiopulmonary system. It is an opportunity to intervene before congestion becomes severe, before hospitalization becomes necessary, before the simple act of breathing transforms from background rhythm to central struggle. The body does not create discomfort without cause. When mild exertion begins to feel unexpectedly heavy, it is often the heart asking for careful attention. Chest discomfort is often imagined as a dramatic, crushing pain that forces someone to stop in their tracks. But in many seniors, the heart does not announce distress with intensity, it communicates with ambiguity. Subtle or atypical chest discomfort is one of the most misunderstood early signs of heart problems in older adults. It may not feel sharp, It may not even feel distinctly painful. Instead, it can present as pressure, heaviness, fullness, tightness, or a mild burning sensation. Sometimes it is not located in the chest at all. It may radiate to the jaw, the neck, the shoulder, the upper back, or even the upper abdomen. Because the sensation is diffuse or unfamiliar, it is frequently attributed to indigestion, muscle strain, or simple fatigue. To understand why cardiac discomfort can be so varied, we must consider the physiology of ischemia, a reduction in blood flow to the heart muscle. The myocardium relies on coronary arteries to deliver oxygen-rich blood. When these arteries become narrowed by atherosclerotic plaque, blood flow may remain adequate at rest but insufficient during exertion or stress. The resulting oxygen mismatch triggers metabolic changes within heart cells. When oxygen supply decreases, cardiac muscle shifts partially toward aerobic metabolism. This leads to the accumulation of metabolites such as lactate and hydrogen ions. These chemical changes stimulate sensory nerve endings within the heart muscle and surrounding tissues. The signals travel through autonomic nerve fibers to the spinal cord and brain. However, the brain does not always localize these signals precisely. The heart shares neural pathways with other regions of the body, particularly the chest wall, neck, jaw, and arms. This overlap explains why discomfort in the heart can be perceived in these distant areas. The phenomenon is known as referred pain. In seniors, changes in nerve sensitivity and pain perception can further blur the clarity of these signals. The discomfort may feel vague or generalized rather than sharp and specific. Another factor is that aging can alter how pain is processed. Sensory thresholds may change. Some seniors, particularly those with diabetes, may experience neuropathy that dulls classic pain signals. As a result, ischemia may present as mild pressure or even just unexplained unease rather than severe pain. This does not mean the underlying issue is mild. It simply means the presentation is different. The character of the discomfort is also important. Cardiac-related sensations are often described as squeezing, pressing, or constricting. Unlike musculoskeletal pain, which typically worsens with specific movements or palpation, ischemic discomfort is more closely tied to exertion or emotional stress. It may appear during walking, climbing stairs, or moments of anxiety. This pattern reflects the dynamic balance between oxygen demand and coronary blood flow. In some seniors, discomfort appears after meals. Digestion increases metabolic demand and redistributes blood flow within the body. If coronary circulation is already compromised, this shift can expose underlying insufficiency. The individual may interpret the sensation as heartburn, yet the underlying mechanism may involve transient myocardial ischemia. There is also a form of discomfort that feels like tightness across the upper chest accompanied by subtle shortness of breath. This combination can be particularly misleading. The person lacks dramatic intensity. The person may continue activity despite symptoms, unaware that repeated episodes of ischemia strain cardiac tissue. From a biological standpoint, ischemia is not merely a pain event. It is a cellular stress event. Repeated reductions in oxygen supply impair myocardial function over time. Even transient episodes can weaken contractility temporarily, a phenomenon known as myocardial stunning. If left unaddressed, progressive narrowing of coronary arteries increases the risk of acute plaque rupture and sudden occlusion. In seniors, subtle chest discomfort should always be evaluated in the context of risk factors. Long-standing hypertension increases arterial stiffness and promotes plaque formation. Diabetes accelerates vascular damage. Elevated cholesterol contributes to atherosclerosis. A history of smoking further compromises endothelial integrity. When these variables coexist, even mild or atypical sensations deserve careful attention. Emotionally, ambiguity can delay action. A crushing pain commands urgency. A mild pressure invites rationalization. Many seniors hesitate to seek medical care because they do not want to overreact. They may minimize symptoms to avoid burdening family members. This hesitation can allow underlying coronary disease to progress silently. It is also important to recognize that not all chest discomfort is cardiac. Gastroesophageal reflux, costochondritis, pulmonary conditions, and anxiety can produce similar sensations. The distinction lies in pattern, triggers, associated symptoms, and risk profile. Medical evaluation, including electrocardiography, stress testing, and imaging of coronary arteries, helps clarify the origin. What makes early recognition powerful is the opportunity for intervention. Medications that reduce myocardial oxygen demand, improve coronary blood flow, or stabilize plaque can significantly lower risk. Lifestyle modifications including dietary adjustments, structured exercise, and smoking cessation directly influence vascular health. When ischemia is identified early, progression can often be slowed or stabilized. There is a deeper lesson within this symptom. The heart muscle, though strong and resilient, depends entirely on its own blood supply. It works continuously without rest. When that supply becomes restricted, the message it sends is not always dramatic. Sometimes it is quiet, persistent, and easy to dismiss. To approach subtle chest discomfort with curiosity, rather than denial, is an act of respect toward the body. It requires neither panic nor indifference, but thoughtful attention. In seniors especially, the absence of severe pain does not guarantee safety. The nervous system may whisper where it once would have shouted, when pressure, fullness, or unexplained discomfort arises during activity and recedes with rest. It reflects a physiological imbalance between demand and supply. It is the myocardium signaling strain through neural pathways that are imperfect but purposeful. Listening carefully to these early signals allows intervention before irreversible damage occurs, before an unstable plaque ruptures, before temporary ischemia becomes permanent injury. There is a quiet clue the body leaves at the end of the day, a sock line that lingers longer than it should, a shoe that feels tighter by evening, an ankle that looks slightly fuller than it did that morning. Swelling in the ankles or legs, known medically as peripheral edema, is often dismissed as a minor inconvenience of aging. Yet in seniors, it can be one of the earliest visible signs that the heart's pumping efficiency is beginning to decline. Unlike fatigue or chest discomfort, which are internal sensations, edema is something we can see and touch. It is physiology made visible. To understand why this happens, we must revisit the fundamental mechanics of circulation. The heart generates pressure to move blood forward through arteries, capillaries, and veins. After delivering oxygen and nutrients to tissues, blood returns to the heart through the venous system. This return flow depends not only on cardiac pumping strength, but also on intact valves in the veins, skeletal muscle contractions, and pressure gradients within the thoracic cavity. When the heart's output begins to decrease, particularly in conditions affecting the right side of the heart or advanced left-sided dysfunction, venous blood returning from the body encounters resistance. If forward flow is insufficient, pressure rises within the venous circulation. Veins, unlike arteries, have thinner walls and are more compliant. As venous pressure increases, fluid is pushed outward from capillaries into the surrounding interstitial tissue. Fluid movement across capillary membranes is governed by Starling forces, the balance between hydrostatic pressure pushing fluid out and oncotic pressure pulling fluid in. When hydrostatic pressure within capillaries rises due to elevated venous pressure, more fluid filters into tissues than can be reabsorbed. The lymphatic system attempts to compensate by draining excess fluid, but its capacity is finite. Over time, visible swelling develops. Gravity plays a significant role in distribution. In ambulatory seniors, fluid accumulates primarily in the lower extremities, the ankles, feet, and lower legs. The longer a person remains upright, the more pronounced the swelling may become. In individuals who are bedridden, edema may appear in the sacral region instead. The pattern reflects physics interacting with physiology. Cardiac-related edema often progresses gradually. A senior may first notice that shoes feel snug by evening. Rings may become tighter. Pressing a finger gently into the swollen area may leave a temporary indentation, what clinicians call pitting edema. This indentation represents fluid displaced within the interstitial space. It is a small but telling sign of altered fluid balance. Why does the body retain fluid in the first place when the heart weakens? The answer lies in the body's compensatory mechanisms. When cardiac output declines, the kidneys perceive reduced blood flow as a threat to circulation. In response, hormonal systems activate, particularly the renin-angiotensin-aldosterone system. These hormones signal the kidneys to retain sodium and water to increase blood volume. The intention is protective by expanding circulating volume. The body attempts to maintain blood pressure and perfusion of vital organs. However, in the context of impaired cardiac function, this added fluid increases venous pressure further. What begins as compensation becomes congestion. The heart struggles to manage the additional volume. and fluid accumulates in dependent tissues. This process can unfold slowly, making it easy to overlook until swelling becomes pronounced. It is important to distinguish cardiac edema from other causes. Venous insufficiency, kidney disease, liver dysfunction, certain medications, and prolonged immobility can all produce swelling. The distinguishing feature of cardiac-related edema is its association with other subtle signs: fatigue, shortness of breath, reduced exercise tolerance. When these symptoms coexist, they form a physiological pattern rather than isolated findings. On a deeper level, edema represents a failure of equilibrium between pressure, permeability, and lymphatic drainage. The vascular system is designed to maintain a precise internal environment. When that balance shifts, fluid escapes the boundaries that normally contain it. The swelling is not merely cosmetic, it reflects systemic hemodynamic stress. There is also a functional consequence. As fluid accumulates in the lower extremities, tissues become less pliable, mobility may decrease. The skin can become stretched and fragile, increasing vulnerability to breakdown or infection. In more advanced cases, fluid may accumulate not only in the legs but also in the abdomen, a condition known as ascites, or in the lungs, worsening breathlessness. Emotionally, visible swelling can be unsettling. Seniors may attribute it to heat, diet, or inactivity. They may attempt to manage it by elevating their legs, which can temporarily reduce accumulation by improving venous return. While elevation is beneficial, it does not address the underlying hemodynamic cause if the heart is involved. Clinically, evaluation may include assessment of jugular venous pressure, listening for heart sounds suggestive of dysfunction, imaging to evaluate ventricular performance, and laboratory testing for markers of cardiac strain. Early identification allows for targeted treatment, diuretics to remove excess fluid, medications to improve cardiac contractility or reduce vascular resistance, dietary sodium restriction to minimize retention. What makes peripheral edema particularly significant is that it reflects a stage where the body's compensatory mechanisms are active but strained. It signals that circulation is no longer efficiently balanced. The visible swelling is the external manifestation of internal congestion. Perhaps the most meaningful perspective is this: the body rarely wastes energy creating symptoms without reason. Swelling is not random. It is a measurable consequence of pressure and volume interacting within a closed system. In seniors where physiological reserves are narrower, even modest cardiac impairment can shift this balance. To notice swelling early is to recognize a signal before crisis develops. It is an invitation to examine the underlying mechanics of circulation, to ask whether the heart is managing its workload effectively, to intervene before congestion progresses beyond the lower limbs. The imprint left by a sock at the end of the day may seem trivial, but within that small indentation lies evidence of fluid dynamics quietly altered by a heart working harder than it should. There are moments when the rhythm inside the chest feels unfamiliar, not painful, not dramatic, but irregular, as though the steady drummer of life has briefly lost its timing. An irregular heartbeat, often described as palpitations, fluttering, skipping, or racing, can be one of the earliest indicators that the heart's electrical system is undergoing strain. In seniors, these sensations may appear intermittently, lasting seconds or minutes, then disappearing as quietly as they came. Because they are transient, they are often dismissed. Yet the heart is not only a mechanical pump, it is an electrical organ. When its rhythm changes, its efficiency changes. The heartbeat begins with an electrical impulse generated in the sinoatrial node, a specialized cluster of cells in the right atrium. This natural pacemaker initiates a wave of depolarization that spreads across the atria, prompting them to contract and push blood into the ventricles. The signal then pauses briefly at the atrioventricular node before traveling through the Purkinje system, coordinating a strong, unified ventricular contraction. This precise timing ensures that blood is ejected efficiently with each cycle. With aging, structural and cellular changes can affect this conduction network. Fibrosis, the gradual replacement of healthy tissue with connective tissue, may develop within the atrial walls or conduction pathways. Long-standing hypertension can enlarge cardiac chambers, stretching electrical fibers. Coronary artery disease can impair blood flow to areas responsible for impulse generation and propagation. These changes do not necessarily cause immediate symptoms, but they create electrical instability. One of the most common rhythm disturbances in seniors is atrial fibrillation. In this condition, instead of a single organized impulse originating from the sinoatrial node, multiple chaotic electrical signals circulate within the atria. The atrial chambers quiver rather than contract effectively. The ventricles receive irregular signals, leading to an unpredictable and often rapid pulse. A person may perceive this as fluttering or a racing heartbeat. Others may feel only subtle irregularity. Even less complex arrhythmias, such as premature atrial contractions or premature ventricular contractions, can create noticeable sensations. These early beats are often followed by a brief pause as the heart resets its rhythm. The pause allows extra filling time, making the subsequent beat stronger and more forceful. This amplified beat is what many individuals describe as a thump in the chest. Why does rhythm matter so deeply? Because timing determines efficiency. When the heart beats, ventricular filling and ejection occur in coordinated sequence. Irregular timing disrupts this harmony. In atrial fibrillation, for example, the loss of coordinated atrial contraction reduces ventricular filling by a measurable percentage, particularly in stiff ventricles common in older adults. This reduction can decrease overall cardiac output, leading to fatigue or shortness of breath. There is also a hemodynamic consequence to sustained rapid heart rates. When the heart beats too quickly diastole, the filling phase shortens. Coronary arteries, which supply blood to the heart muscle itself, primarily fill during diastole. A shortened filling period reduces myocardial oxygen supply precisely when demand is elevated. Over time, this imbalance can strain cardiac tissue. Irregular rhythms also influence blood flow dynamics within the atria. In atrial fibrillation, stagnant blood in the quivering atrial chambers can form clots. If a clot dislodges, it may travel to the brain and cause a stroke. This risk underscores why even seemingly mild palpitations warrant medical evaluation in seniors. Not all irregular heartbeats produce obvious symptoms. Some individuals are highly sensitive to minor rhythm changes, while others remain unaware of sustained arrhythmias discovered incidentally during examination. The variability in perception reflects differences in autonomic tone, individual sensitivity, and the frequency of irregular beats. The autonomic nervous system plays a central role in rhythm stability. Sympathetic stimulation increases heart rate and excitability, while parasympathetic input slows conduction. In seniors, shifts in autonomic balance due to stress, illness, dehydration, or medication can precipitate arrhythmias. Electrolyte imbalances, particularly involving potassium and magnesium, further influence electrical activity at the cellular level. At the microscopic scale, cardiac rhythm depends on ion channels embedded in cell membranes. These channels regulate the movement of sodium, potassium, and calcium ions, generating action potentials that propagate through myocardial tissue. Aging, ischemia, and metabolic disturbances can alter channel function, increasing the likelihood of abnormal impulse formation. Emotionally, palpitations often generate anxiety. The heart's rhythm is closely tied to our perception of stability. When it feels irregular, it can create a sense of vulnerability. Anxiety itself can increase sympathetic tone, further accelerating heart rate and intensifying the sensation. This feedback loop can blur the line between primary arrhythmia and stress-induced symptoms. Clinically, evaluation may involve electrocardiography to capture rhythm patterns, ambulatory monitoring over days or weeks to detect intermittent events, and echocardiography to assess structural changes. Blood tests may evaluate thyroid function and electrolyte balance. Treatment depends on the specific rhythm disturbance, ranging from medications that control rate or rhythm to anticoagulation therapy when stroke risk is elevated. It is essential to recognize that occasional isolated premature beats in otherwise healthy hearts can be benign. The concern arises when irregularity is persistent, symptomatic, or associated with other signs of cardiac dysfunction. In seniors, where structural heart disease is more common, vigilance becomes particularly important. The heart's rhythm represents coordination at its finest, billions of cells depolarizing in near-perfect sequence. When that sequence falters, efficiency declines, and risk may increase. Palpitations are not merely sensations, they are evidence of altered electrical conduction within a living, dynamic organ. To pay attention to irregular heartbeat is to acknowledge that timing matters as much as strength. A heart can be strong in muscle yet unstable in rhythm. Early recognition of electrical disturbances allows intervention before complications arise, before sustained tachycardia weakens the myocardium, before a silent clot forms within an atrium no longer contracting with purpose. Within the subtle flutter or unexpected pause lies a message about conduction pathways, ion gradients, structural integrity, and hemodynamic consequence. The rhythm of the heart is both mechanical and electrical, both physical and symbolic. When it shifts from steady cadence to unpredictable pattern, it invites careful listening and thoughtful response.